Good morning to everybody. So my name is Joanna Vergitas. I'm a medical oncologist at BC Cancer in Victoria. This is my first time participating at Kidney Cancer Canada, so I'm very grateful to have this opportunity to participate today. I'll be moderating this session on standard of care and latest developments in kidney cancer. I'd like to introduce and invite up our panel. And so I'd like to bring Dr. William Chu up forward. He's a radiation oncologist in Toronto. Dr. Anil Kapoor, when he has a free moment, to come up as a uro-oncologist representative in Ontario as well, and Dr. Christian Colemannsberger, medical oncologist at BC Cancer in Vancouver. All three are leading experts in the field who contributed nationally and internationally with various research programs and several collaborations. And what will happen, as mentioned, is each will have an opportunity to speak for a few moments about developments in their own respective specialty, and then we'll open it up to the floor for questions that you may have. So, Dr. Chu, yeah.
Thank you very much, Joanna. Thank you. Thanks very much, Joanna. First and foremost, thank you to Kidney Cancer Canada and the Kidney Cancer Research Network of Canada and you, the patients, for the opportunity to come and speak with you today to talk to you about stereotactic radiotherapy for patients with renal cell carcinoma. I'll begin with the case. This is a very pleasant woman that was sent down to me from Barrie, Ontario for an opinion now, probably about 7 or 8 years ago. She was an obese woman who had multiple medical comorbidities. She's had prior heart attacks, COPD, breathing dysfunction, as well as severe diabetes, and her kidneys weren't functioning very well with a baseline creatinine of 250. In 2010, she was diagnosed with a clear cell renal cell carcinoma in the left kidney, as you can see here highlighted on the arrow. Unfortunately, she was not a candidate for surgery, despite experts that are available in Ontario, like Dr. Kapoor. The thought was, with the interventional radiologist, which they sent her for an opinion, is that she could potentially be a candidate for radiofrequency ablation, which you'll hear about potentially from Dr. Kapoor. But unfortunately, it was 3.5 centimeters, 4 centimeters in size. So the plan was to potentially shrink the tumor by embolizing, shutting off the bloodstream, which fed the tumor. But during the procedure, unfortunately, she had a code blue, wound up in the ICU for about 4 or 5, 6 months. And ultimately, within that year post her traumatic experience with the embolization, the tumor grew to over 6 centimeters in size, and she was no longer a candidate for RFA. And at the same time, her nephrologists were preparing her for dialysis, given her worsening renal function. So the question is, what was left to do for this patient? Surveillance is an evolving treatment option, but not for patients like this where we know tumors are growing and with multiple medical comorbidities. The question was what to do, and then sent her down for an opinion with me. Is radiation a possibility? Historically, radiation was felt to not to be a perfect match in terms of a therapeutic modality for kidney cancer because of radiation resistance, but it's not true in 2019. Our technology and technological advances now allow us to deliver super high doses, highly sculpted radiation treatments to tumors with what we call very steep dose gradients, meaning our ability to focus the radiation just to the tumor while minimizing the excess radiation dose to the neighboring adjacent normal organs or tissues. Stereotactic radiotherapy has a number of advantages. It's non-invasive therapy, it's outpatient treatment. We're not limited, particularly in kidney cancer, of where it's located, whether it's on the periphery or to the central area, close to the vasculature or the urinary collecting system. Data to date suggests that shows that it's well tolerated, it's safe, and it's relatively low cost. There are key 4 tenets or essentials that need to be followed in order for us to successfully deliver stereotactic treatment for patients with kidney cancer. We need to see the tumor, so that allows myself and other radiation oncologists to define the tumor target accurately. We need to manage the movement of the kidney, because as you breathe, everything in the abdominal organ, abdominal cavity moves as your lungs expand from the head to the toe. And then our radiation technology and computing power and systems allow us to develop very focused radiation plans to the tumor, and then our ability to see the tumor before we actually turn on the radiation is also very important. We use advanced imaging like MRI and CT scans. We fuse them at the time of planning so that we can actually define the target. We know here, we're not going to show it, but kidney tumors move as you breathe, and this is what that video would show. When you go through your radiation planning or mapping appointments, you have a customized cushion with vacuum compression to really minimize the amount of breathing to allow us to focus the radiation on the tumor target with minimal movement or excess radiation to the adjacent normal tissues. We use 4-dimensional contrast imaging, meaning CT planning, meaning we capture all phases of the breathing cycle before we actually deliver the radiation treatment. And then when we take those pictures, as you go from this picture, this is the scan, this is the tumor in the left kidney, we've defined the target in the red, but more importantly, we've also defined the normal tissue that's very close to the tumor. Here is the small bowel, and here is a loop of colon within less than a centimeter from the target. We then do high-level calculations with super fast computing power such that we deliver and plan the radiation to cover the tumor highlighted in red with super close, high doses of radiation, and within less than a centimeter, the amount of radiation that touches your small intestine or the colon is actually super low. We use real-time imaging before we actually turn on the beam. We make sure that the position of the tumor is exactly where it was at the time of the mapping appointment before we actually deliver the radiation treatment. This is just to highlight that stereotactic radiotherapy is effective in controlling tumor growth, but it takes time. Typically with patients receiving stereotactic treatment, in the short term, tumors actually may get bigger or swell as a result of the radiation, but sometimes it can take upwards of 18, and data from Harvard shows more than 2 years for tumors to actually start responding or shrinking in size. What are the paramount objectives for radiation treatment is patients generally come and see me when they have borderline renal function. We know that based on data to date that radiation treatment via SBRT is very good at maintaining patients' baseline renal function. There's really no significant knockdown in comparison to surveillance, radiofrequency ablation, or surgery itself. We're in the same ballpark. So who would be a classic patient eligible for stereotactic radiotherapy? On imaging, it's growing, it's increasing complexity. We ideally want to have a biopsy. The tumors are large. In our series at Sunnybrook in Toronto, as well as worldwide, the majority of patients receiving radiotherapy for the kidney tumors were generally on the average about 4.5, 5 centimeters in size. So certainly not in the scope of the size that normally would be eligible for radiofrequency or thermoablative techniques. We also want patients who we're seeing who are non-operative candidates. They've been discussed in a multidisciplinary case conference, seen by the surgeon, as well as the interventional radiologist, and felt this patient probably be best suited with a non-invasive approach like stereotactic treatment. Thank you very much.
We might defer the questions all to the end, and we'll just go to the next speaker.
Who's next?
Dr. Bohr.
Good morning. Sorry I was late this morning. It's a little surprise, I know. So I'm going to talk about adjuvant therapy as one of the innovations. One of the innovations we talked about last time for those that were here was surgical innovation with robotics, nanotechnology, laparoscopic surgery, and single port surgery. We can go back to my slides. Okay. So I think that the big thing that's happened in innovation is taking out just the tumor and saving the organ. Just in a nutshell, what used to happen is that we would take out the entire kidney with a radical nephrectomy, do an extensive resection, but now what we're doing is with these new technologies is precisely taking out just the cancer with a very high cure rate. And sorry, you can go back to my original slide there. Oh, this is not working? Okay. All right. And so just taking out the tumor itself with a negative margin and saving the organ behind is really the goal of robotics, of laparoscopic surgery, very precise surgery, cryoablation, radiofrequency ablation, killing just the cancer and saving the rest of the organ and preserving overall kidney function. Now, if you go to the next slide, we're very happy with the results of surgery, but once we take out the cancer, there's still some rate of reoccurrence based upon the biology of the cancer. So it's based upon the size of the tumor and the grade of the tumor. So we talked yesterday about the staging for kidney cancer. Anything less than 7 centimeters is a T1 lesion, first stage cancer. Between 7 and over centimeters, it's a T2 lesion. And T3, or stage 3, is if it's into the veins of the kidney cancer itself, and T4 is if it's the organs around it. So you have stage 1, 2, 3, and 4 for surgical resection of cancer. Then we have, you can see in this patient, this is a patient from my practice who had a large cancer, and we see that it's T3N0M0. What that means is that there was no lymph nodes, and in general, we don't take out lymph nodes unless they're bulky. If there's no lymph nodes to take on the CAT scan, then we don't resect the lymph nodes routinely. We get that question all the time, and there's lots of data showing that there's no point in taking out minor lymph nodes that are not enlarged because it doesn't benefit, and only if they're larger and bulky do we take lymph node sampling. M0 stands for metastases, and that's when the cancer spreads beyond the kidney. So in this patient, he had a large mass. It was a T3, large cancer, but there was no nodes and there was no metastases. He did have some medical issues, and we did this left nephrectomy. It was clear cell carcinoma. There's different types of pathology. Clear cell is the most common type, and there's papillary and chromophobe, non-clear cell. And there was 25 sarcomatoid element, which means the cells inside the cancer itself were more aggressive. So he's cured, the cancer is out. So we're very happy. We have that meeting with him, and we talked the fact that your cancer is out, you're cured as of this moment. But there's a risk of reoccurrence. For a T1 lesion less than 7 centimeters, a risk of reoccurrence is less than 1 to 2%, which is fantastic, very high cure rate. But for T3, a large tumor, 10 centimeters, the risk of reoccurrence is almost 50%. Next slide. So we do have some data from this, and this is a complex graph, but if you look at the boxes, for patients that are T2, T3, T4, their reoccurrence at 5 years can approach up to 40% for T3. And so it can be fairly high for this, especially if the grade is high as well in those boxed categories there. And if the nodes are positive, certainly the risk of reoccurrence is high. So we have the meeting after the surgeon. We say the cancer is cured, but these are the reoccurrence rates. And all patients ask, what can I do to prevent this cancer from coming back? And that's with the innovation for the future is how do we prevent these cancers from coming back? And that's called adjuvant therapy. And a lot of patients ask, well, what does that mean? And adjuvant therapy means a therapy after a curative intent surgery. Right? So you can have post-operative therapy, which is a drug which Christian's going to talk about for any metastases or nodes. But if you have no cancer and you want to go on a drug, that's called adjuvant therapy to try and increase the cure rate. And that's the focus of what I'm going to talk about for innovation. Surgical innovation, where we've done a lot of great work in precise surgery using robotics and laparoscopic surgery. But what about adjuvant therapy? Next slide. This is another classification system, and there's no boxes around them. But if you look at the high-risk localized disease bar there in the middle, and you can see the recurrence rate is up to 55%. And so this is important data because I think as urologists, we need to do a better job with our patients saying, and many of my colleagues do say that the cancer is gone, you're cured, I'll see you back in 6 months with your CAT scan. But I think patients deserve to know the numbers and say, okay, your risk of reoccurrence for a 10 centimeter tumor is 50% in 5 years. And so that's sobering numbers, but there's a 50% chance of cure, but what else can we do? Next slide. So the ideal adjuvant therapy is something, a drug that acts at very high, for those patients at very high risk of reoccurrence, T3, T4, has to be active on these microscopic cancer cells. For example, if you have somebody who has a kidney cancer with a large tumor, if you take a blood cell, you can actually look at circulating tumor cells or CTCs under a microscope. And so our hope is that the patient's own immune system kills those microscopic cells, but sometimes it doesn't in 50% of patients. So we need some drug that's active on that. Low toxicity, and the reason why that's important is when somebody has metastatic cancer, they're very compliant with their medication because they want these metastases to go away. But if somebody is cancer-free, most patients just want to go back to work and then put it behind them. And so if you have a drug that's toxic, Patients don't usually take it because, they say, I'm done, I'm going to go back to work, and I don't want to take this drug anymore. And it has to be relatively inexpensive because there's a lot of patients that have these surgeries, more so than metastatic patients. And it has to have a meaningful outcome. Next slide. So I'm not going to go through all these studies in detail. I just have 3 or 4 more slides, but these are the studies that are out there suggesting that adjuvant TKI, or tyrosine kinase inhibitors, is negative. That means that patients that take pazopanib or sunitinib or any other, or sorafenib after these TKIs don't act on microscopic cancer and high risk for recurrence patients. Now, they are very active for metastatic patients, and Christian will talk a little bit more about that, but for non-metastatic patients, these trials are negative, and basically they don't help patients live longer going on these drugs that we've studied in these trials. And for those of you that were in these trials, we appreciate your support in these trials, because it does answer a meaningful question. And in my practice in Hamilton, we did offer this PROTECT trial and the STRAC trial, and unfortunately the PROTECT trial was a negative trial. The STRAC trial, which is an adjuvant sunitinib, these are patients that had their cancer out, then went on sunitinib for a year after the surgery. They did show it was a positive trial, but with what's called disease-free survival and not overall survival. I'll go over that in the next slide. Next slide. This is it. These are the trials in just a single slide here. The ASSURE trial was a trial that patients had large cancer, that they had the surgery done, were randomized to a drug called sorafenib or sunitinib or placebo, and they actually showed that the patients on placebo lived longer than the sorafenib and the sunitinib. So that shows that really these drugs didn't help patients live longer in that first trial. In the second trial, this is the STRAC, this is high-dose sunitinib, or sunitinib 50 milligrams, 37.5 milligrams compared to placebo, and this actually showed a disease-free survival benefit. What that means is that it delayed the onset of the metastases for a year, but when they compared the patients in both arms, they lived the same length of life. So going on adjuvant sunitinib didn't help you live longer, but delayed the onset of the metastases. I think that's a meaningful endpoint, that you did have delay of metastases, but the most important is to live longer, obviously, and so that STRAC trial didn't have that so far. The PROTECT trial was adjuvant pazopanib or Votrient, and that was a negative trial as well. Next slide. So there's a reason why, and so patients are very educated. Many patients do a lot of research on this, which is great. We love to have informed patients about this, and patients are, even Christian is sometimes confused about these kind of results, saying, okay, well, adjuvant sunitinib worked in STRAC, but did not work in, sorry. So
coming from a surgeon.
Last slide, yeah. Patients are confused because the ASSURE trial was negative. It showed that patients who took sunitinib didn't live longer than placebo, and placebo did better. Whereas in the STRAC, they delayed the onset of metastases about a year, and patients find, I agree that that's a meaningful endpoint. But why is the difference? And the reason why is that on this slide is that the STRAC patients took a higher dose of drug. So what we conclude from these adjuvant TKI studies is that if you take a higher dose of drug, 37.5 or 50 milligrams, with the associated side effects, it will delay the onset of the metastases. But again, the overall survival is about the same. Next slide. So we need to do better. So I think the bottom line is adjuvant TKI may not be beneficial to patients, but there are some patients that are motivated to take adjuvant sunitinib, and I think it's an important discussion to have with patients. Adjuvant sunitinib is approved by the FDA in the US for patients at high risk for recurrence. It's not yet approved in Canada for that indication, but it is an option for patients, and I think the discussion is important to have with patients. This is where we need to go in the future, is adjuvant IO trials. And so there's 4 drugs out there. There's atezolizumab, there's pembrolizumab, there's nivolumab, and there's ipilimumab. And so you can say those, if you can say all those over and over again 10 times, you get $10. But all these adjuvant IO drugs are fantastic drugs, and they have a good effect for patients with metastatic cancer. And we're very pleased with these complete responses, up to 10% with patients on nivolumab and ipilimumab with metastatic cancer. What about if you don't have cancer, but you've had your surgery? What about taking these drugs for a year afterwards? Well, we don't have the answer yet, but I think this is the way to go in the future. And these are the 4 trials that are being offered across the country for patients that have had surgery and want to go on something afterwards. This is called the Emotion, which is a trial randomizing atezolizumab versus placebo. This trial is actually closed because it's immediate its recruitment. And so we eagerly await the results of this trial in about 2 or 3 years to see if it benefited patients. I think it'll be positive, but let's see what the data shows. The keynote for surgery with pembrolizumab versus placebo. This is still being offered across the country. And there's the Prosper trial, which is going to be activated, which is before surgery, giving a dose of nivolumab. And I think this is an exciting thing to give before surgery to see if we can sterilize any micrometastases before the surgery, and that may be a good option for patients as well. I'm excited about that one. I think that's very promising. And the last one Dr. Kolsonberger offers here in Vancouver is the adjuvant nivolumab ipilimumab after surgery. And if anybody's having surgery and you have a T3, T4 in discussion with your urologist, give Christian a call. I'll give you his cell phone number. You can call him directly anytime. So the number is, no. Next slide. So this is my summary here. I think in terms of innovations in surgery, we've had precise surgery for cancers with laparoscopic, robotic surgery, nanotechnology is coming through. We're very excited about that. But still, the biology of the cancer dictates the recurrence rate. And if you have a larger cancer, a more aggressive cancer, we do need these adjuvant therapies. And the bottom line is the adjuvant immuno-oncology trials will read out in the next couple of years. And we have this form in 2 or 3 years. We'll have the results of those trials. And I think they'll be very promising for patients. Thank you. One more slide. I'm going to go for a second round of applause after this. So this is a patient in my practice. This is a true case again. It's a 38-year-old family doctor. He had some blood in his urine, and obviously a young man with a family, young children, came in and he was shocked because he never smoked, did everything right. And this, again, bad things happen to good people, and he was surprisingly had a mass in his kidney. He never had any family history of cancer, didn't smoke, didn't drink, and he found to have this large mass. Very, very nervous about this, and again, this is where the individualized discussion happens. Many patients say, I've had the surgery, I'll take my 50% chance, and I'm just going to go and have some beer. I think it's a very great option for patients, unless you don't drink beer. But I think going to a trial is really what we prefer for patients, and I think that it's an option to go. And so this patient did go into an adjuvant IO trial. We don't know what arm he's in because he's blinded, but his CAT scans so far are negative, and he's in Club NED, I like to call it. Club NED is no evidence of disease, and that's where we all want to try and go to, is Club NED. Thank you.
Yes, so it's now my turn. And I would just briefly give you a very quick insight into where we are in terms of treatment options for patients with metastatic disease. Can I have the next slide? Oh, you trust me with the clicker? That's good. Thank you. C. I just want to give you a very brief kind of historical overview, just to demonstrate how much progress we've actually made in the treatment of kidney cancer over the last 10 to 15 years. I came to Vancouver in 2004, and there was exactly one treatment for metastatic kidney cancer, that was interferon, and that treatment was applicable to about 25% of metastatic kidney cancer patients. 75% of metastatic kidney cancer patients went without any treatment, best supportive care. And then between 2004 and 2010, we developed a number of treatments. So we had about 4 different drugs approved. And since 2010, the number of approved drugs has increased to 12. So that demonstrates how quickly research, what we talked before, spits out new drugs. And they are not all very different drugs. Some of them are similar. But just the fact that we have now so many treatment options is very encouraging. And along those lines, what happened was that we increased the number of treatments our patients have access to. As you probably all know, these drugs are fairly excruciatingly expensive, and it is a big big burden on the healthcare system, but we've managed with our collective efforts to do actually very well. As it stands right now, it appears that probably as of May, June, we will have 3 lines of therapy for each and every one of our patients, which is great because that gives us a lot of flexibility in how to treat our patients. What are we trying to achieve when we have patients with metastatic disease? Well, we try to shrink the tumors. That's what we call tumor response rate. We try to prolong the interval without tumor growth. That's what we usually refer to as progression-free survival. When you read on studies, that's what that means. We like to extend life. That's what we call overall survival. And ideally, and that has been something which in the past has happened rarely, we try to cure patients who have metastatic disease. And that appears something which we actually have started to see. What drugs do we use? We use targeted agents. A lot of you are familiar with that: sunitinib, pazopanib, axitinib, cabozantinib, sorafenib. And those are agents which interfere with specific mechanisms in or around the tumor, which are important for the tumor cells to survive. So we try to block that, and by doing that, we try to kill the tumor cells. And what is now new is this new generation of immunotherapy or biologic therapy. And what we are trying to do is we try to use the body's own immune system to fight the cancer. The drugs which are currently in clinical use, nivolumab, ipilimumab, pembrolizumab, avelumab, the list is growing almost on a monthly basis. Since these drugs are developed by almost every company now. And this armamentarium gives us a great number of tools to select the right treatment for the right patient. What is this immunotherapy about? Ipilimumab is a so-called CTLA-4 inhibitor. All these treatments are based on blocking certain mechanisms in the immune system which puts the brakes on the immune system. Your immune system is a constant interplay between activating and breaking signals because you want to fight diseases, but you don't want to have an overshooting reaction. And CTLA-4 and PD-1 are 2 of those mechanisms which basically slow the immune system down for a good reason if you are a healthy person, but not so good if you have cancer, because what cancers do is they exploit those mechanisms to hide. They display information and say to the immune system, don't attack us, we are part of your body, don't do anything with us. And the 2 gentlemen you see here last year received the Nobel Prize for Medicine because they discovered these basic principles of the immune system, which then subsequently allowed to design drugs which can literally take the brakes off. And those are the CTLA-4 inhibitors. The representative we have in clinical practice is ipilimumab. And then the PD-1 inhibitors, nivolumab, pembrolizumab, which we are now rapidly introducing into the treatment of our patients. Now, as anything we do, nothing comes without a price tag. And apart from being very expensive, these drugs can have side effects. And that is something which we have to learn and have to get experience with, and you have to be aware of. I always tell my patients when we discuss immunotherapy that immunotherapy is very well tolerated until it is not. And why do I say that? Because if you are on a TKI, sunitinib or pazopanib, there's a good chance that you will have ongoing aches and pains from side effects, hand-foot syndrome, indigestion, high blood pressure, all these kind of things which you deal on a regular basis with. Immunotherapy, if it is well tolerated, most of the patients have actually 0 symptoms. But what can happen if you take the brakes off the immune system? You can overstimulate the immune system to the point that the immune system starts to react with normal, healthy body tissues. And then you can get side effects which can be very unpleasant, can actually be life-threatening, and require rapid and expert care. And that is something which we need to educate our patients for, we need to educate our colleagues for, because a lot of patients go to emergency rooms, and if the doctors there don't know that the patient is on an immunotherapy agent, that may cause problems. So that is something which we all have to work on, to educate ourselves about these side effects so that we can can promptly treat them and make it a safe journey for our patients. So when we look at the history and the current situation of treatment options for metastatic patients, I think we've seen that there's a rapidly increasing number of drugs. For the first time, it appears that long-term remissions, I'm carefully with the word cure because we don't have enough follow-up yet, but for the first time, it appears that long-term remissions may be possible in a larger group of patients. We don't still have any tools which would allow us to rationally assign treatment. That is a huge gap, and this is where a lot of research is invested. Can we measure something in patients or in the tumor which would tell us this patient is best treated with a TKI or is best treated with immunotherapy? We don't have that yet, but we are working on that. It's important to realize that despite our best efforts, all of these therapies can have side effects, and we need to do a lot more studies and trials to really figure out how to best use these treatments. And last but not least, and this is something which we all collectively need to work on, is the financial impact of these drugs can be prohibitive in the future in introducing them, and that is something which we need to overcome. Thank you.
Thank you. I'm happy to open it to the floor if there are any questions. Yeah.
I'm just curious about the two lines of drugs. I've been on 2 different TKIs. I'm on Sutent now. I was on nivolumab for 9 months, and I had exactly what, as you described. I thought it was a miracle drug for 9 months until I had a severe reaction. Had to go off it. So the TKI drugs, I started sapanib, Sutent, then they say axitinib will be the next one. Is the same true for immunotherapy? So if I failed with Nivo, can I try one of those other immunotherapies? Or am I going to likely end up with the same reaction?
The absolutely correct answer is we don't know. It is highly likely that if you had sunitinib, axitinib, pazopanib, they are similar drugs, but we do know that they actually can work one after the other because they are not clean drugs. They don't just block one mechanism in the cell; they block lots of mechanisms, and that is they all block the main mechanism, but they are different in what else they block. And I think in this, what else they block is probably why they work one after the other. That does not necessarily apply to the immunotherapies. If you've been on nivolumab and then you go on pembrolizumab, they're very similar drugs. They just come from a different company. But in all their properties, all what they do, they seem very similar. So it is actually highly likely that if you had an adverse reaction, a severe adverse reaction to one, that you have a high risk that that happens with the other. We cannot say that with absolute certainty because we are a little bit chicken when it comes to that. We don't like to put our patient's life at risk by trying it again. I think over time we will get experience with that, and this question will be answered. But for the time being, if you have to leave an immunotherapy line of therapy for side effects, for severe side effects, then I think it is fairly risky to introduce another one down the line. If you were taken off because your tumor didn't respond or stopped responding to the drug, that's a different question. There is a very large number of new and novel immunotherapies coming very rapidly, and it may well be that in the future you have an immunotherapy, and if that doesn't help, then you can go to another immunotherapy.
Another question for Dr. Kommelsberger. So you set out, I've had surgery, I'm now on the drug trial, as you know, and just as a general question, how do oncologists decide after a point in time that their treatment is not working? How do they decide to go to a second or third line of therapy?
So I think if I understand your question correctly, it has two components. How do we decide that a drug does not no longer work? That's what we use CT scans for, where we measure tumors. We just simply look whether they are growing or not. And we also look at how patients feel. If patients develop new symptoms, if patients were doing well and then all of a sudden develop weight loss, no energy, no appetite, those are signs that the drug obviously doesn't work anymore. Or if the CT scan shows that patients develop new tumors, or the existing tumors grow and grow fairly significantly, those would be signs of tumor progression. Now, the second part of the question is, how do we decide which drug is going to be next? And that is a very difficult question because, as I pointed out, we don't really have any tools which would allow us to rationally choose the next drug. The decision is based on our experience, on the studies we have. What is the next drug which most likely can control the tumor? It depends on the individual situation of the patient. What has the patient received so far? How has the patient tolerated it? What other comorbidities, what other illnesses does the patient have? What can I give him? And so all of that comes into that decision when we decide which drug we're going to use next.
I would also add, we do have a organization called the Kidney Cancer Research Network of Canada. That's the research arm of KCC, Kidney Cancer Canada. And we put out guidelines for our oncology community about what to sequence. So we're just publishing those shortly in a couple of weeks based upon the recent trials out of ASCO that Dr. Kolzenberger has talked about in his talks. And so we have some guidance for oncology community as to which drug to rationally choose next line. But as you said, it's based upon the data that we have, and we have to look at the trials that are most appropriate for the individual patient. So looking at your pathology, your factors, how you responded, and seeing which drug is better for you based upon the trials that have been done. And we have some guidance for our oncology community, so it's standardized across the country.
It's also important to note, I highlighted the role of stereotactic radiotherapy in localized or primary kidney cancer, but certainly in the space of metastatic disease, there's certainly growing more utilization, and certainly on every patient's case is different, but it depends on the number of metastases and which ones specifically that may or may not be growing. The potential philosophy is that we can try to maintain you on the same type of drug therapy if we're just trying to, let's say for example, the tumor, the ones that are behaving badly, potentially stereotactic radiotherapy can zap those bad guys and so that you can continue on the same drug therapy or delaying the change or continuing on resistant therapy down the road. And certainly that's an area and space that's evolving. There's a greater role of stereotactic radiotherapy in patients like with oligometastatic or oligoprogressive metastases. So something to think in mind and have a conversation with your oncologist about.
So that is something which is important, and I think when we have patients where we suspect that the tumor is growing, we look at all the treatment options in entirety with the whole team, with the surgeons, with the radiation oncologists, with the interventional radiologists, if there's a chance to do radiofrequency ablation or SBRT. And I think that is a very important point, and if you get treatment, you should ask those questions, do I have a situation where maybe some local treatment can help me and can solve the current situation? I think these things are important because kidney cancer treatment is a team sport, and often you can get away with continuing treatment. If I can reference an example, Stephen is the best example for that. His tumor grew according to the standard definition on sunitinib treatment, and we radiated that spot and continued with sunitinib. So that does not always work with every lesion, every patient, and there's a limit to what you can do. But it's a very good question to ask when your doctor confronts you with the diagnosis your tumor is growing. If something like that can be done, that often is a very elegant solution to that problem.
Hi, I instructed him not to give the microphone to the audience, and he was going to fight me. Well, he's a police officer, so I know he'd win. Question for, I think you bring up a good point. I would like to talk a little bit about if we could talk a little bit more about SBRT, Christian, because at the time that options were made available to me, I was told about options on the spine. They said to me, you've got 3 options. Dr. John Street here said, 1, we can resect the vertebrae where the tumor is located. It's a 30% morbidity rate. You're going to have a flap in your back for a period of about 6 to 8 months. 2 was to embolize it, to put essentially crazy glue into the vein that was beating it and try and shut it down. And 3 was SBRT, radiation. But we don't have that here. And I wonder, is it very often that, and I think all the clinicians can join in on this conversation, is when a patient comes in, they often walk away and think, well, they don't have this is all that's available to them. Should the question being asked of clinicians be, is that just what's available to me here at this location at this specific time, or are there other options available outside the geography of maybe your local community, your province, your center, even the country? I just wonder that because I mean, we know within our community that certain drugs, for instance, may appear in Europe before they appear here that may have a benefit to us. Would you all mind just commenting on that?
Yeah, there are different philosophies on this question. My philosophy is that I want the best for my patient, so I do not talk to my patient from the viewpoint. I only talk about what we have available. I think that's a mistake because at the end of the day, it's the patient's decision what he wants to do with this information. If the patient wants to fly to Toronto to see Will, then that's fine. If the patient wants to fly to Hamilton and get operated by Anil, that's fine. And I didn't say it was a mistake.
Did they get a robot?
You know my opinion on that. And the same applies for clinical trials or drugs which are not funded in Canada. If I think that's the best for my patient, I would at least talk to them and talk to my patient about the obstacles to get there. In reality, often these options are out of reach, unfortunately. But I think it is at least worth a discussion. Now, to put a little bit of a plug for our healthcare system here in Canada, I think in most provinces we are actually fairly well equipped right now for kidney cancer, what we can do and what we cannot do. So I think, especially for kidney cancer, we are not in a dire situation right now that we don't have access to drugs we should have access to, etc. That may come in the future. Just to give you kind of a perspective that's not meant to threaten you or anything, just to give you food for thought that this is going to be a society question, not a question of patients and doctors. It's going to be a question for our society, how much money we want to spend on healthcare. When I came in 2004 in BC, the cancer drug budget was $50 million. Last year, the cancer drug budget was $350 million. And it's growing by 10 to 15% per year. Now, 10 to 15% of 50 is a lot less than 10 to 15% of 350. Just to give you a perspective of what we are facing in the coming years. But I think in kidney cancer, and if the latest information we received about the availability of drugs now with the introduction of immunotherapy comes true, through the way they pictured it, then I think we will actually be fairly okay.
I just have a couple of comments on that as well.
That's the point.
Oh, here it goes. Okay. We've known each other since for many, many years. Yes. And when he started, again, he gave the wrong year. They had horse and buggies back then, I think, right? It's okay. So I think it's a loaded question. You kind of touched on this yesterday about quality of care and making sure that every patient has access to all the best treatments. And should this all be regionalized at the academic centers? We're all he's at U of T, he's at UBC, I'm at McMaster. So we're able to offer patients the cutting edge care now with SBRT and all the various options for drugs and clinical trials. But every patient should have that option. I'm not sure what the periphery is here in Vancouver, but in North Bay and Ontario and other peripheral cities, those patients also should be offered cutting edge care. And I think that's where education is important, education of the oncologist. That's where the COA comes in, and Tiffany Pizzioli is going to talk about that in a few minutes, about the role for education of doctors. And I think the community oncologist, if they can't offer it in North Bay or the peripheral city, they should send it to the city that can offer it. And I think that's where the education comes in. All patients want to be treated in their local city. We have patients that come in to my office from Sault Ste. Marie, from Sudbury, from North Bay for surgery. They really want their surgery done locally, but we coordinate the care with their home city, and I think that's important for cutting edge SBRT, cutting edge clinical trials, as well as surgery, is to have that education for the community oncologist. I don't think everything needs to be regionalized. Every patient needs to be seen at the academic centers all the time, but the outreach is important so that everybody's communicating and educated about the best options across Canada. KCC partnering, Kidney Cancer Canada partnering with COA to educate all the oncologists and patients so they're aware well is very important.
And I just want to echo what Christian and Neil have said, and how critical and what a pivotal piece that Kidney Cancer Canada plays as an organization for you, for the patients. And we talked about this yesterday, is that, you know, when we see patients in the clinic, they should get an immediate referral, not only for seeing us as an oncologic specialist, but also referral to Kidney Cancer Canada, because, you know, we do our best to try to stay on top and informed as possible of all the options available to you. But certainly Stephen and KCC are kind of developing a greater, more vital role to getting you the latest and greatest information, just a point and click of a button. And as Neil said, you know, knowledge translation and patients asking questions and getting access to clinical trials in the local communities is certainly a growing and essential aspect of patient care. And certainly with organizations like Kidney Cancer Canada, allow me, an individual with stereotactic experience, to run research trials and highlight the importance of research so that we can actually bring the technology and the treatment for patients like yourself in your local community, but also allow myself and the teams and we as a group to become more educated, more up to date, and up to speed with the technology and giving patients access to the latest radiotherapy treatment techniques.
While I agree with everything said, I think for you as patients and caregivers, I think it is very important that you inform yourself when you are confronted with a situation like that. And you know, inform yourself, where are the local centers, are clinical trials going on, et cetera, so that you can make an informed choice to say, yes, I may seek another opinion or not, and maybe I'm interested in something like that and I would like to learn more about that. I do think that is very important.
So we have 5 minutes left, maybe one more question.
Hello, my name is Leslie, and my kidney cancer was discovered by accident. I was having back problems, and anyways, it was discovered that I had kidney cancer. And back in 2012, I had a Whipple procedure. And if anyone knows about that, I'm not going to go into all the details, but pretty well your whole insides are put differently, to put it mildly. And it's you get a lot of cutting inside. And it took a long time for me to get over that. But anyways, still not sure I'm over it. But after that, I was put on Sutent. And it did good for many years. Now I have another situation that has come up, and I'm just wondering if going from Sutent right into immunotherapy is where you go, or is there other pills that can take the place of going from one dramatic thing to another, which I'm quite frightened of doing right at this point. But if it's saving my life, well, then that's fine. But I'd like to know if there's any other treatments in between those two things.
Going from sunitinib to immunotherapy is one of the options. There are other options. You can go for a patient from sunitinib to another pill, such as axitinib. before you consider immunotherapy. That, again, depends on the individual situation of the patient, and it has to be discussed with your oncologist. But it is not a must that you have to go next immediately to immunotherapy. That is not necessarily the case.
By the way, I was given 27 months to live, and it's 7 years later, so I hope.
Well, thank you very much for the questions and comments. Oh, is there one more? Okay, sorry. Yes.
Sorry, I'll say a comment and a question. So Kidney Cancer Canada, we have some great information which you've all referred to on our website, so it's a good way of getting engaged with your own treatment. But you also talk about the patient getting informed. So how do you deal with Dr. Google versus some of the other websites and information sources that have valid information versus some information that could be suspect?
I sometimes. Pardon me? That would be a good question for the afternoon session. I sometimes bring a little coffee cup into my clinic, which says, "Don't confuse your Google search with my medical degree."
Where can I get that?
Thank you again for the questions and comments, and to our panel members for their excellent talks and their time. Thank you.